is Dr. Neelam here. I have finished my MBBS in DNB Emergency Medicine, and so far throughout my journey, I found airway to be the most important topic for a clinician managing a sick patient. So, thought of sharing the same. Here, I'll be discussing the anatomical and the physiological aspects, and in the further videos, I'll be sharing even the airway assessment and the airway management as well. So, let's start. Let's see first why is it so important. First is for decision making. Uh, for example, while managing a sick patient in the emergency department requiring an airway management, first rather than directly jumping and managing airway, directly managing airway, first we have to plan and prepare for the airway management. So knowing the anatomical and the physiological aspects and the difficulties anticipated, we'll be able to prepare for the difficult airway equipments the earliest and call for help accordingly. So it is very important for the decision making. Second is structure and function. So knowing about knowledge of the airway anatomy and its dynamic changes, it facilitates the appropriate performance of airway opening skills and bag mask ventilation. This skill depends on an understanding of the functional airway anatomy and how the tissue behaves when the patient is either awake or in an obtunded state. Okay, so next coming to its importance, landmark recognition. The landmark recognition, sound 3D appreciation of the laryngeal inlet and its surrounding is very important for optimal laryngoscopic performance. Anatomic structure which is adjacent to the glottic openings such as the epiglottis and the paired arytenoids, interarytenoid cartilage. All this helps to provide a roadmap to the cords. So knowledge and able to identify these structures are very important while performing a laryngoscopic procedure. Next is spatial orientation. This is particularly when using a blind or an indirect tracheal intubation technique. A clear mental image of the anatomy through which the instrument is traveling is required. Next, coming to airway. Airway is divided into upper airway and lower airway. Here in our topic, we'll be discussing in detail about the upper airway. Lower airway basically consists of trachea, principal bronchi, secondary bronchi, segmental bronchi, terminal bronchiole, respiratory bronchiole, alveolar ducts and sac. This is how a sagittal image of the sagittal section of the airway looks, wherein it consists of nasal cavity, oral cavity, pharynx, and the larynx. This is the upper airway. So we shall discuss each in detail and starting with the nasal cavity. Herein we'll be only discussing mainly the important clinical, anatomical and physiological aspects rather than detailed anatomy, which is more important for while performing a procedure. So nasal cavity is basically the functional beginning of the airway, and it helps for warming and humidification of air. The mucosa of the nasal passage is basically very extremely fragile and vascular and is susceptible to trauma easily. It's basically supplied by the internal and the external carotid artery, uh, that is through its branches, that is the anterior ethmoidal nerve and the sphenopalatine nerve. So one should keep in mind that uh, as it is a vascular structure, it is wise to consider the use of vasoconstricting agent when appropriate to help avoid epistasis, which may obscure further attempts at securing an airway. Although patient tolerates nasal intubation better than oral intubation for a longer period of time, but oral intubation is easily performed, and in an emergency setting, it is better to go ahead with oral intubation. So next, coming to the oral cavity. Oral cavity is basically consisting of mouth, palate, tongue. Oral cavity is mounted anteriorly by the alveolar arch of the maxilla, the mandible, and teeth in the front. And above it is bound by hard and the soft palate, and below by anterior two-third of the tongue, and the reflection of its mucosa forward into the onto the mandible below, and the oropharyngeal isthmus behind. So let's see the important aspects only. So, as the upper maxillary teeth, especially the upper left central canine, while performing a laryngoscopic pro procedure, is most risky of injury, but even the lower and the back tooth can be injured. So one has to have a repeated practice on doing a laryngoscopy by in the simulation center to avoid hinging upon the teeth and injuring the teeth while performing the procedure. Next, epiglottis. Functionally, it separates the oropharynx and the laryngopharynx at the root of the tongue. Jaw thrust maneuver uses the sliding component of the temporomandibular joint to move the mandible and attach tongue anteriorly, thereby relieving airway obstruction caused by the posterior displacement of the tongue into the oropharynx. Mouth opening is an important parameter for intubation, and its assessment is as important while performing a airway procedure. And even protrusion of the anterior teeth, it also is one of the important component while performing an airway assessment. Malampati score is again a scoring scale for estimating the size of the tongue according to the oral cavity, which is important prior to attempting an airway to know the difficulty anticipated while performing the laryngoscopic procedure. But in an emergency setting, these assessment is usually not possible when a sick patient is on the table. This is how a oral cavity basically looks. As I have already mentioned about the boundaries uh, previously. Next, coming to the pharynx. Pharynx is basically a tube-like passage that connects the posterior nasal oral cavity to the larynx and the esophagus. It is divided into three parts: oropharynx, nasopharynx, oropharynx, and the laryngopharynx. The pharynx is a muscular tube extending basically from the base of the skull to the level of the cricoid cartilage, and it connects the nasal cavity, oral cavity, and the larynx, as already told. Nasopharynx, that is between the nares and the hard palate. Velo or retropalatal oropharynx, a term used to describe the part between the hard palate and the soft palate. Second is the oropharynx, from the soft palate to the epiglottis, and hypopharynx from the base of the tongue to the larynx. So as already I told that it's a muscular passage, it consists of 20 or more airway upper muscles surrounding the airway. So these muscles in the awake patient helps to maintain airway patency. And one more important aspect in the pharynx is the inner lobe of the superior laryngeal nerve. It basically passes into the submucous part of the pyriform fossa. Local anesthetic solution applied to the pyriform fossa surface may provide anesthesia for the vocal strands. During laryngoscopic procedure, this fossa may be useful as a nerve block supporting oral anesthesia. Next, coming to larynx. Larynx is basically a complex structure which is made up of cartilage, ligaments, and muscles. It serves as an entry to the trachea, and basically its performance is for airway protection and phonation. The anatomical position is important, its composition, the musculature associated with it, and the innervation of the larynx, which all contributes to the anatomical structural capabilities. The cartilaginous frame of the larynx is made up of nine cartilages, three paired and three unpaired. The three unpaired ones are the epiglottis, the thyroid cartilage, and the cricoid cartilage, and the three paired ones are the arytenoid, the corniculate, and the cuneiform. So let's see the important anatomical aspects. The laryngeal prominence, which is appreciable from the anterior neck, it serves as an important landmark for percutaneous airway technique and laryngeal nerve blocks. So, able to appreciate the prominence is very important. Cricoid cartilage, it encloses the subglottic region of the larynx. Basically, cricoid cartilage is a ring-like structure, as uh, uh, it is a unpaired cartilage and it is a ring-like structure. Uh, Unless the other cartilage, which is only bounded anteriorly or posteriorly, this is bound throughout 360 degrees of the larynx, and stenosis may form if the mucosa in this region is injured, as can occur with the prolonged endotracheal tube intubation or an improper technique. Fibrosis or fixation of the cricoarytenoid joint, as can be seen with rheumatoid arthritic patient or falling trauma, must be kept in mind in such cases anticipating. The larynx during direct laryngoscopy begins with epiglottis, which is a cartilaginous flap that serves as an anterior border of the laryngeal entrance. Next, coming to, this is the image on the right side. Uh, it is the external appearance, how the larynx basically looks. Here is the hyoid bone. This is the thyroid cartilage. Here is the cricoid cartilage. And attaching each other are the ligaments seen. This is the epiglottis, which is appreciated here, but while performing the laryngoscopy procedure can be appreciated well. This is how an internal inlet uh, or the larynx basically looks internally, and these are the structure. This is the epiglottis, which can be appreciated while performing a laryngoscopic procedure. Coming inside, here we can appreciate the thyrohyoid membrane. This is the hyoid bone, and the arytenoid cartilage. Above the arytenoid cartilage are the corniculate cartilage, and ligaments of crico, uh, cricoid and the thyroid can be seen here in the sides. This is how a graphical representation is basically seen while performing a laryngoscopic procedure. This is actual image how it looks while performing a procedure. So appreciating each and structure in and around the glottic opening is very important. Like while performing, we have to go very slow with the laryngoscope rather than just pushing in the laryngoscope inside. First, we should be able to appreciate the push the tongue and go inside and appreciate the vallecula and then the epiglottis. And upon lifting the epiglottis, we'll be able to appreciate the vocal cords. We should even be able to appreciate the posterior structures like the arytenoid cartilage and the interarytenoid ligaments as well. This is the image which I have added on to show the difference between the laryngeal inlet and the esophagus. Sometimes it may be confusing, hence it is very important, and repeatedly I am telling that we should be able to appreciate each and every structure around the vocal cords rather than just seeing the vocal cord and trying to intubate. Next, coming to the nerve supply. Nerve supply, I'll be dealing it in detail in the nerve blocks. Highlighting on it, just nasal cavity is basically supplied anteriorly by the anterior ethmoidal nerve, posteriorly by the sphenopalatine nerve. Tongue is basically anteriorly two-third is supplied by lingual nerve and the posterior one-third by glossopharyngeal. Extending on posteriorly to pharynx is supplied by glossopharyngeal nerve. Larynx above the vocal cord is supplied by the internal laryngeal nerve, and below the vocal cord is supplied by the recurrent laryngeal nerve. Next, coming, this was the discussion on anatomy so far in general. Now we'll just see how is pediatric airway different from the adult airway, and the just seeing the difference here and how we'll manage these differences. We'll be discussing it later. Okay, the head basically is larger than the body in pediatric. While performing the head is larger. So while performing a procedure as to bring the laryngeal, pharyngeal and oral axis in the same line, we will have to keep a pillow or a bedsheet, wrapping a bedsheet and has to be placed below the shoulder to bring the three axes, that is oral, pharyngeal, laryngeal axis in the same line. Next, the facial skeleton basically is smaller in neonates when compared to the neocranium, which is bigger. Oral cavity is small at birth. So basically, while using bag mask ventilation, we should be very careful in such smaller kids to use an appropriate size of the mask accordingly. And even the bag mask ventilation procedure must be repeatedly practiced prior to attempting on a pediatric patient. Tongue has a flat surface and limited lateral mobility and appears relatively large in a small mouth space, so which makes the laryngoscope procedure little difficult while going inside. The larynx appears more prominent during direct laryngoscopy since it is the larynx is higher up and it is anteriorly placed. So external manipulations allow basically external manipulation will allow direct laryngoscopic procedure to be easily carried in such case. Epiglottis is a long, narrow and usually U or V shaped and it is floppy in pediatric. So while performing a procedure, the blade used basically is a Miller's blade, which is a straight blade used for the pediatrics. Next, coming to glottis. Glottis is higher up in newborns at the level of C2 or C3, and after 2 years it falls back to normal position, that is at the level of C5. And vocal cords are usually shorter, so appropriate size of the tube must be selected accordingly to prevent stenosis such area. And subglottis is the narrowest part in the pediatric, whereas glottis is the narrowest part in the adult. Next, coming to the congenital diseases associated with uh, airway anatomical difference. So, Chart syndrome is basically associated with corneal atresia, and micrognathia, glossoptosis, and cleft palate is seen in syndromes like Treacher-Collins syndrome, Pierre-Robins, and Stickler syndrome. Maxillary hypoplasia is seen basically in Crouzon syndrome, Alport syndrome, Pfeiffer syndrome, Golden Heart syndrome, and trisomy 21. Macroglossia is seen in trisomy 21 like with Widman syndrome and achondroplasia. Laryngeal abnormalities can also be seen in conditions like laryngomalacia and other conditions like airway hemangioma, subglottic stenosis, and vocal cord paralysis, which can be congenital. Next, we'll see the difference in airway in an obese patient and how it is different from the other normal patient. A patient will have a short, thick, immobile neck, which caused by the cervical spine fat pad and which interferes with the rigid laryngoscopy, wherein extension of the neck is limited in such obese patient. Redundancy of the soft tissue structure inside the oropharyngeal and the supralaryngeal area may also make visualization of the laryngeal structures difficulty while performing laryngoscopy. Mass ventilation also is difficult in an obese patient due to the fat pad, the buccal fat pad, and the fat around the neck. And obese patient will have a residual functional residual capacity. So hence pre-oxygenating such patient very well is very important prior to attempting a laryngoscopic procedure. Next we shall see how pregnancy is pregnant patient is having a different difference between in the airway anatomy and physiology. The mucosa of the upper respiratory tract becomes more vascular and edematous, which increases the risk of bleeding, swelling in the airway. Airway edema may be exacerbated by preeclampsia, oxytocin infusion, IV fluids, and Valsalva maneuver during labor and delivery. Decreased functional residual capacity and increased oxygen requirement accelerates the onset of desaturation during apnea and hence has to be kept in mind before sedating and paralyzing a patient. And patient has to be pre-oxygenated well in such condition. Progesterone basically reduces the lower esophageal sphincter tone, which results in gastric reflux, and this can be increased due to delayed gastric emptying after a painful delivery and opioid administration. Hence, they are at high risk of aspiration. Enlarged breast makes laryngoscopy procedure difficult.